Thank you. I realize Durkee and I have 35 minutes between us. Is that right? I'm going to have to talk fast?
Yes. Not too fast, because we want to...
I know. I tend to talk fast anyway. Anyway, thank you very much for inviting me, Leo. This has been a very nice meeting. And I'm happy to talk a bit about a facet of severe asthma we call steroid-resistant or steroid-insensitive asthma. And what does that mean? I'm going to talk a little bit about the pathobiology, show some cartoons, but I'll take you through it. First, I want to start with a case. This is a 38-year-old woman with severe persistent asthma who's been on chronic oral steroids, present with worsening shortness of breath that began about 3 days ago. Her child was also sick at home. She uses her short-acting beta agonist every 2 to 3 hours, and she's on chronic methylprednisolone at 16 milligrams daily, but increased it to 48 milligrams about 2 days ago. She has a very active asthma history in that she was diagnosed at age 9, has had 30 to 40 hospitalizations throughout her life, including one endotracheal intubation. She's been dependent on steroids since 2003, and as we heard from Dr. Bell, she has all the comorbid conditions we tend to see in asthma, including reflux, allergic rhinitis. She has a history of nasal polyps. These are her medical issues, as I mentioned, and I won't go through them all, but they're very familiar and are seen very commonly in severe asthma, and this is one of my patients, actually. She is aspirin sensitive, which would go along with the nasal polyps, and so taking aspirin causes rash and wheezing. And she's on a lot of medication, and I think the important issue here is the methylprednisolone, on high-dose combination therapy. She's on a leukotriene modifier, which we would expect for aspirin sensitivity, and a number of other medications. Her pulmonary function test on presentation, as you can see, this is the forced expiratory volume in 1 second. She is at 1.27 liters, or 48% predicted. Her forced vital capacity is 2.4 liters, or 78% predicted, resulting in an FEV1 to FVC ratio of 53%. So this is consistent with severe airflow limitation. So this patient is representative of a steroid-resistant patient in that she is on chronic steroids. She gets some benefit from them, but in fact, she needs higher doses to really benefit the same way as many of our milder asthmatics might benefit from much lower doses. So why is that? Well, as we heard from our earlier speakers, Dr. Breitling talked a lot about phenotypes, and so did Dr. Bell. We're really moving towards that in asthma. And in fact, this treatment resistant could be considered a phenotype, but I think it's really an extension of disease severity. And when we think about it, we think of steroid or treatment-insensitive asthma as actually another term used. So there's a number of sort of different acronyms thrown around, but it's about 5 to 10% of patients with asthma are steroid insensitive. And this phenotype or category of asthmatics carries a very high burden, both economically, but also with regards to morbidity and mortality. And these are the patients certainly that keep me up at night in my own practice. So if we think about an asthmatic airway, I just want to show you a few of the changes that you would see, and you would absolutely see this in a steroid-resistant situation. So this is the airway epithelium, and you can appreciate how nicely organized it is in the normal situation, with some cells in the submucosa. But if you compare it to an asthmatic airway, you can appreciate a very disrupted epithelium with increased goblet cells here, a thickened subepithelial basement membrane, and lots of inflammatory cells. And in fact, if you take a look, or a closer look, if you will, of the airway epithelium in asthma, you can appreciate how disrupted and abnormal it really is. And we know that the epithelium not only is a barrier, but it actively participates in the inflammatory process. And this is a lung biopsy from a 4-year-old patient with steroid-dependent, and I would say steroid-resistant asthma, and you can see a lot of really abnormal changes, including a very heaped-up, irregular epithelium. You can see this thickened basement membrane, as I showed you, and lots of inflammatory cells. So clearly, patients who have steroid-insensitive asthma have very severe disease and have a lot of comorbid conditions and potentially even mortality as well. And in fact, we know these patients also can produce increased mucus, and this is really what can result in mortality, in that this mucus really results in lack of ability to ventilate and death. So how do steroids work? So I thought what I would do is talk a little bit about how they're supposed to work, and then tell you where some things might go wrong in steroid-resistant asthma. So we know that GC stands for glucocorticoids. They diffuse across the cell membrane into the cytoplasm, and then they bind to a receptor in the cytoplasm, and it forms a complex. And then this complex moves into the nucleus and binds to parts of the DNA that can result in gene transcription of anti-inflammatory genes, or they can inhibit the transcription of pro-inflammatory genes. Now, this process requires also the recruitment of coactivators that contain intrinsic histone acetyltransferase activity, and I'm going to talk a little bit more about that. So this allows local acetylation of histones and causes remodeling of DNA and RNA polymerases to change and alter gene transcription, because the goal of this is, of course, to decrease inflammation. And this receptor can also bind directly to the DNA, or it can bind indirectly by interacting with a number of factors like NF-kappa B, which is a central mediator that I'll tell you more about. So here's a cartoon where you have the glucocorticoid binding to the receptor in the cytoplasm, forming a complex with heat shock proteins. These heat shock proteins dissociate, and you have this complex here that moves into the nucleus, binds to specific elements on the DNA, and alters transcription. Now, this is an older cartoon, so I want to give you a little more updated cartoon, which now we have some new information suggesting there's more than one of these heat shock proteins here, and I'm going to talk a bit about their importance. But when this complex moves into the nucleus, you can see there is binding to DNA to cause anti-inflammatory gene transcription, and this is mitogen kinase protein 1, or MKP1, and also can inhibit pro-inflammatory gene transcription. So it's the sort of the yin and the yang of what these complexes can do. Now, before these receptors even get to the nucleus, there's a number of steps, but the key message here is this histone deacetylators have gotten a lot of attention, and this one is called HDAC6. And the reason that's important is it actually can deacetylate this heat shock protein so that it can bind to other chaperones to then form this very activated glucocorticoid receptor complex. So we've really learned a lot more, I'd say, in the last 10 years about all the steps involved for steroids to work. And then once this complex exists, it can bind to steroid here, move into the nucleus, and alter transcription. So what can go wrong to induce this resistant state? Well, you can have issues with receptor isoforms and binding. You can have a reduction in binding affinity of the receptor to the steroid. There can be defects in how the receptor or the complex gets to the nucleus. And you can have epigenetic mechanisms. And actually, there's some really interesting data that are recent suggesting that infectious agents in the microbiome may actually alter steroid sensitivity. So let's talk a bit about the receptor itself. Well, it turns out there's two different kinds. There's GR, or glucocorticoid receptor alpha, which is the active receptor. And then there's an alternative form called GR beta. And it does not bind to steroid. And so type 1 steroid-resistant asthma is due to reduced binding affinity, in contrast to type 2, which is due to reduced receptor number. So this GR beta forms a complex as well with the active receptor, and then decreases the ability of this receptor to move into the nucleus and bind to the DNA. So this GR beta is found on inflammatory cells such as neutrophils and the airway epithelium. Now, there's a lot of debate about this alternative receptor, depending on what school of thought you belong to. Some investigators think there's not enough GR beta around in severe asthma to be relevant. There's another group who thinks that there are enough of these receptors. So we can debate, but that's sort of where the state of the art lies. And the expression of this alternative receptor is induced by cytokines we see in asthma, such as IL-2, 4, 13, and TNF-alpha in some cases. And so a while ago now, Donald Leung and his group in Denver looked at patients who were normal, who had steroid-sensitive asthma and steroid-resistant asthma, and made a discovery that the binding affinity, this KD, is different depending on what kind of asthma you have. The higher this KD, the lower the binding affinity. So those patients who had steroid-resistant asthma had much lower binding affinity of their steroid receptor compared to those patients who had steroid-sensitive asthma, and certainly compared to normal patients. And in fact, this binding affinity could be induced, or alterations in this binding affinity could be induced by two cytokines, interleukin 2 and 4. And this is done ex vivo, looking at peripheral blood mononuclear cells. So it's interesting that the combination really induced this change. And it's thought, the mechanism is thought to be due to alterations in translocation into the nucleus. And in fact, they went on to show that these patients also expressed a lot of this GR beta. These are the glucocorticoid insensitive asthma patients compared to those who have steroid-sensitive asthma and normals. And you can see maybe about 20% of these are peripheral blood mononuclear cells express this alternative receptor. So I would say that would be pretty significant. And in fact, our lab looked at this as well in patients at different times of day, in patients who had nocturnal worsening of asthma. We did this a long time ago, and showed that in fact at night there was an alteration in steroid sensitivity, which was worse than during the day, and about almost 50% of airway cells expressed this receptor. And in fact, it looked like the macrophage was the cell that had the highest expression. And in fact, when we inhibited interleukin 4 and interleukin 13, two cytokines we think are very important in asthma, we actually decreased the expression of GR beta. So it's a very fluid process, and that this receptor expression really seems to be induced by the type of inflammation we see in asthma. All right, well, what about some other problems? We know that oxidative stress is thought to impair translocation, so remember that's movement of the complex into the nucleus. And that is thought to be a mechanism of steroid resistance in the smoking asthmatic and even in COPD. I mentioned already that IL-2 and 4 can impair translocation. And another interesting fact is inhaled steroids and long-acting beta agonists can actually improve or enhance translocation more effectively than either alone. And this has been shown both in vitro and in vivo. Now, once the complex gets into the nucleus, it binds to the promoter and induces MKP1 expression, as I mentioned, also interleukin 10, which is a cytokine that suppresses inflammation, so that's a good thing. But we also see impaired MKP1 in steroid-resistant asthma, and this results in P38 MAP kinase expression, and I'll show you a little bit of a diagram for that. But what's interesting is this induction of interleukin 10, which we would like to see in asthma, by T cells is impaired in steroid-resistant asthma, but reversed by vitamin D. So vitamin D is part of this process in that it has a role in steroid responsiveness as well as in other functions like host defense. And in fact, obesity, we were just hearing about that from our previous speaker, Dr. Bell. Obesity is actually a state of reduced steroid responsiveness. And it turns out that the more obese you are, the less able you are to induce this MKP1, remember that's an anti-inflammatory gene, and in fact it's proportional, or it's correlated with your BMI. And the mechanism is thought to be increased TNF that is seen in obesity, because the greater the BMI, the more TNF is seen. So that's thought to be the mechanism, although it hasn't been conclusively proven. Now, the vitamin D issue is particularly interesting because there are other cytokines that we're seeing in some types of asthma that aren't particularly steroid sensitive, and interleukin 17 is one of them, and you've been hearing a little bit about that today. And it turns out patients with asthma express more IL-17, this is in their peripheral blood mononuclear cells, and IL-22. Now it turns out if you expose these cells to vitamin D, you can appreciate a significant reduction in both IL-17 and 22. And you'll notice the steroid, dexamethasone, didn't do very much. So vitamin D has a role in reversing, or at least attenuating, steroid resistance. Now, now the complex gets to the DNA, and there's an interaction going on between the yin and the yang, the ability of the steroid to suppress inflammation, yet all the processes that are going on to induce inflammation. And NF-kappa B is really a key mediator there. And this increased NF-kappa B activity has been shown in corticosteroid-resistant asthma. And the last issue I want to show you before sort of putting it all together for you is this question of epigenetics. Now, in the resting cell, chromatin in the DNA is highly compact and not accessible to transcription factors. But during activation of the cell, Gene transcription is associated with histone acetylation. So those histones I was showing you earlier, well, they also work in the nucleus. And it's through this enzyme called histone acetyltransferase. So this anti-inflammatory action is due to the deacetylation. So the acetylation causes inflammation, deacetylation suppresses inflammation. So a group of enzymes that deacetylate are called HDACs, histone deacetylators, and they've been getting a lot of attention in asthma as a way to reverse the steroid-resistant state. And in fact, there's a study actually a couple of years ago looking at HDAC2 in asthma, in the airway cells and in peripheral blood mononuclear cells, and especially in the airway, they are expressed at much lower amounts in steroid-resistant asthma. Remember, the HDACs are the good guys. HDAC1 didn't see much change, so HDAC2 is also important. So this cartoon sort of puts it all together because I've given you a lot of information in a very short time, so let's go through it. So the glucocorticoid binds to the receptor, forms a complex here, and wants to move into the nucleus, but there's a bunch of processes going on that try to reverse that. One, GR beta can get in the way and inhibit translocation. There can also be cytokines and such that can actually cause degradation of the receptor. You can have problems with your HDAC here and your heat shock proteins because if they're not deacetylated appropriately, they can't bind to the receptor to form an active complex. So once the complex is in the nucleus, yes, it wants to bind to these elements of the DNA, but HDAC2 has to be around in order to keep the receptor effective and allow it to inhibit NF-kappa B. Now, interestingly, theophylline actually increases HDAC2, and that's been studied as a potential therapy for steroid-resistant asthma. There's a few investigators that are big believers in this. LABAs improve translocation, and this is to remind me to tell you that smoking can actually decrease this process. Oxidative stress can impair steroid action. So, what are some clinical implications? We talked about obesity, we talked about vitamin D. Well, it turns out that even common viruses can cause steroid resistance. And this is a very recent paper by one of the members in our audience, Dr. Pappy is first author, looking at rhinovirus. And in fact, rhinovirus can impair the ability of the steroid to move into the nucleus. And these are the percent of glucocorticoid receptor positive cells in the nucleus. In the setting of rhinovirus, that amount is very low. And certainly compared to the presence of steroids, and even if you put steroids and rhinovirus together, there's much less movement into the nucleus. So infections can cause a steroid-resistant state. And another recent study looking at the microbiome in severe asthma has identified a particular bacteria, Haemophilus parainfluenza, that also, this is a complicated slide, I just want you to focus on this one column here, shows a very little induction of this MKP1, and really, and as well, and so therefore induces a state of steroid resistance. And so the mechanism is really what I've already told you. It's thought to be due to the impaired ability to induce MKP1, and therefore what happens is this whole process of inhibiting the NF-kappa B activation and interleukin-8 production doesn't happen, and so IL-8 is allowed to be produced and contribute to inflammation. So can we make a better steroid? They're not all perfect. Well, there is a type of steroid called a dissociative steroid that has a non-steroid backbone that can suppress NF-kappa B but not have the same side effects that a typical steroid has. And we heard the list of steroid side effects. They're very significant. We'll hear a little bit about ultrafine steroids from our next speaker, so I won't say anything about that. And lastly, there's combinations of inhaled steroids and perhaps MAP kinase inhibitors, or PD phosphodiesterase inhibitors that inhibit specific enzymes that have bronchodilating properties and not that have side effects. So I moved fast today in the interest of time, so I'm happy to take questions or talk to any of you afterwards about some of these mechanisms. But I think steroid insensitivity is an important aspect of asthma pathobiology that represents an unmet need. I think it's complicated, we don't understand all the mechanisms, and we don't have all the answers yet in how to target therapy more effectively to circumvent these processes. I think concepts have evolved to include vitamin D, its role in steroid sensitivity, obesity, infectious agents, microbiome, as well as all the histone acetylators and deacetylators. And I think if we can produce corticosteroids that focus upon anti-inflammatory actions or combination therapy that can antagonize mechanisms of steroid resistance, for instance, like our new biologics, anti-IL-13 and anti-IL-4, 5, could have benefit in this area. I believe those are key future directions. So thank you very much.
Thank you, Dr. Kraft, for your complete and interesting talk. The discussion is open. Only one question. One question.
No questions. Okay, that's bad. It means nobody understood what I said. Go ahead.
No, I think you address a very important point that is actually cross with COPD. Mm-hmm. I think you hear. And so the obvious question to you is what is the comparison in looking at steroid insensitivity?
Right. Well,
you know, but the more general question, the answer will be short, is in general, you know, when you have a remodeled, transformed fibrotic tissue, like you have in asthma, severe, and you have in COPD, you have in liver fibrosis, is it any really intervention that is actually reversing that is actually overriding the steroid resistance that is common to all these different conditions?
Well, that's a tough problem because what we aren't very good at is once the remodeling has occurred, really to reverse that. Unless perhaps it has to do with smooth muscle, if you are a believer in thermoplasty, and that's very controversial, and I'm not sure that I am, but I think that's probably the one treatment that focuses on that compartment. I think what we can do is really try to identify the process early because we can actually intervene. I think smoking is a perfect example. If we can have our patients quit, we've removed a big oxidative stress that we know can induce steroid resistance. There's actually therapies that can induce these HDACs, these histone acetylators, and I think that's a really interesting aspect of therapy that really we haven't exploited entirely yet and may have benefits in really reversing some of those processes that have to do with movement of the receptor into the nucleus and activation. So that's another area that I think is particularly interesting. But I do agree. I think we've got to identify these processes early before that airway becomes remodeled.
Thank you.